interest of time. So, when we talk about mitral regurgitation or any type of valvular pathology, you have to understand what we're talking about. Okay? So, when we say mitral regurgitation, the definition of mitral regurgitation is the flow of blood across the mitral valve from the left ventricle to the left atrium. And this occurs when the left ventricle contracts. So when the left ventricle contracts, instead of blood going solely across the left ventricular flow tract, across the aortic valve and into the aorta, you have blood also flowing across the mitral valve into the left atrium. The mitral valve is supposed to be competent. That is, in systole, when the left ventricle is contracting, the mitral valve should close firmly and prevent blood from flowing backwards into the left atrium. So if the mitral valve is incompetent for whatever reason, you can get blood flowing backwards from the LV into the left atrium. And that's why it's also called mitral incompetence, because the mitral valve is incompetent. So the incompetence of the mitral valve could be from anything. If you just think about it a little bit, the incompetence of the mitral valve could be secondary to the mitral annula being dilated. So when the valve closed, there's a gap between the leaflets. Or it could be a problem related to the valve itself. The valve may be destroyed from, say, endocarditis, an infectious process, or some other thing. So anything that prevents the valve from closing properly can and will give you mitral regurgitation. So that's the basic definition, and you have to visualize this. You have to understand it thoroughly in order to determine what follows. Okay, so mitral regurgitation is a systolic phenomenon. Okay, remember when you're doing echo, you divide things into diastole and systole. Mitral regurgitation occurs when the left ventricle contracts. Okay, the normal scenario is for blood to flow across the left ventricular flow tract, across the aortic valve, and into the aorta. But if there is mitral incompetence, you're going to have blood flowing backwards from the left ventricle across the mitral valve into the left atrium. Okay, so that's the basic definition of mitral regurgitation. The mitral regurgitation have multiple causes. So as mentioned before, it could be due to stretching of the mitral annulus, or it could be secondary to incompetence of the valve itself. The valve may be destroyed. So in the United States, mitral valve prolapse is one of the most common cause for mitral regurgitation. And mitral valve prolapse goes by many other names. You'll see Barlow syndrome, myxomatous degeneration, among a few. With mitral valve prolapse, you have a redundancy of the valvular apparatus. Okay, there's a redundancy of the valvular apparatus, and the valve does not close properly. To make the diagnosis of mitral valve prolapse, we usually use the parasternal long axis view. And there is an imaginary plane that we use, and if the valve comes close to that or go beyond that, the anterior mitral leaflet, that is. And you can have mitral valve prolapse of the posterior leaflet as well. So if the anterior posterior leaflet goes beyond that plane, you can make the diagnosis. But majority of the time it's clear cut. You can see that the valve is bowing backwards towards the left atrium, and you can make that assessment. With mitral valve prolapse, if the anterior leaflet is prolapsing, then the jet, the mitral regurgitant jet, will be directed posteriorly. And if the posterior leaflet is prolapsing, the jet will be directed anteriorly. Okay? And that's different if you have like an ischemic mitral regurgitation. All right, so that's mitral valve prolapse, the most common cause. Ischemic heart disease can also give rise to mitral regurgitation, and that is because if there's insufficient blood flow to the mitral valvular apparatus, and usually the papillary muscles, usually contract and helps to maintain competency of the mitral valve. However, if the papillary muscles are not getting sufficient blood flow, they're not going to contract properly, and you can get mitral regurgitation. So it's fairly common because ischemic heart disease is fairly common. So ischemic heart disease is one of common cause. Rheumatic fever again. However, if you have mitral regurgitation secondary to rheumatic heart disease, the valve is going to look rheumatic. So remember, we went over mitral stenosis. So you'll get the acoustic configuration of the anterior mitral leaflet. Not only that, but the valve is going to be thickened, probably calcified, and you're going to have restriction in the motion of the valvular leaflet. So if you see a case of rheumatic mitral disease, you can readily say that's rheumatic. Marfan syndrome. So we're accustomed for Marfan syndrome. These are these individuals with their tall, their upper extremities, the wingspan, so to speak, is very long. That is from fingertip to fingertip on the both sides is usually greater than their height, and they tend to have scoliosis, curvature of the spine. They have some lens problems, but cardiac-wise, they will have aortic. They'll have aortic aneurysm, ascending aortic aneurysm, and that aneurysm can also rupture. Okay, they can also present with mitral valvular problems and mitral regurgitation. So that's your Marfan syndrome. The Ehlers-Danlos, those are those individuals who, you call them elastic man or something like that. They can bend themselves into different figures because there's a laxity of the joints. They also will have some aortic aneurysm as well, and mitral regurgitation. They can develop pathology of the mitral valve. Dilated cardiomyopathy, patients who have a dilated heart because of stretching of the mitral annular ring, the valve become incompetent. So they can also present with mitral regurgitation. Non-compaction cardiomyopathy is just another form of a dilated cardiomyopathy. The mitral annular ring will be dilated, so you're going to have poor coaptation of the mitral valve, and hence mitral regurgitation. Endocarditis, infection of the valve. If there is any pathology on the valve, it's going to prevent proper closure of the valve, so you will get some regurgitation. Signs and symptoms, again, anything that affects the heart, can shortness of breath, probably chest pain, that sort of stuff. So, you can work it out. So, again, shortness of breath, dyspnea, okay? And the shortness of breath first will be exertional, and then if it's pretty bad, then you have shortness of breath at rest. Orthopnea, you have to sleep on multiple pillows, or sleep in the chair. PND, okay, paroxysmal nocturnal dyspnea. They go to bed, wake up a few hours later, panting, short of breath. If the mitral regurgitation is pretty severe, patients will develop heart failure. That is because instead of pumping blood across the left ventricular flow tract, across the aortic valve into the aorta, you're pumping majority of the blood backwards. So the forward cardiac output, so to speak, is going to be very reduced. They're going to flood the lungs with blood, so they will very short of breath. So they can present with congestive heart failure. Decreased exercise tolerance if you have significant mitral regurgitation because of the reduced cardiac output. Palpitations. Patients will remember one of the compensation when you have heart failure, the heart rate goes up, so become tachycardic, and they can get irregular beats. So they will tell you, patient will tell you that they have palpitations. Or the systolic murmur at the apex radiating to the axilla. This is the classic murmur of mitral regurgitation. Remember, mitral regurgitation occurs in systole when the LV contracts, okay? And blood is going across the mitral valve into the left atrium. So it's a systolic phenomenon. It's going to occur all throughout systole. That's why we call it holosystolic. It's heard best at the apex. It increases with expiration. Remember, all left-sided murmur is going to increase with expiration, and it's going to radiate to the axilla. So if you hear this murmur and the location is such that it's at the apex, radiate to the axilla, it's almost always mitral regurgitation. Because the heart is usually displaced, because one of the things, significant mitral regurgitation will give you left ventricular dilatation. So the heart is going to be enlarged. So when you check for the PMI, point of maximal intensity, or the apex, it's going to be displaced, usually inferior laterally, okay? And then if the patients have mitral valve prolapse, you will hear the so-called mid-systolic click, okay? So mid-systolic click suggests that the patient has mitral valve prolapse. All right, so this is your echocardiogram, and again, this is your parasternal long axis view, okay? This is your right ventricle right there, or right ventricular flow tract. This is your septum, your LV cavities right there. This is the posterior wall. This is your mitral regurgitation, okay? The left atrium is right there. The aortic valve is closed. The aortic valve is open, okay, because it's systole. Remember, in systole, the aortic valve open, the mitral valve is supposed to be closed. It looks as if the mitral valve is closed, but it's incompetent. It's incompetent, so that's why blood is flowing from the LV across the mitral valve into the left atrium. Your transducer is right there. The blood is flowing away from the transducer, hence it is different shades of blue, or if there is significant turbulence, you're going to get a mosaic, which is a mixture of the color. Okay, so your classic MR, mitral regurgitation, okay? All right, so this is your apical four-chamber view, okay? Transducer is right there. This is the LV cavity, This is your mitral valve. This is the anterior mitral leaflet, the posterior mitral leaflet. This is the mitral regurgitation. Okay, it's a systolic phenomenon. Okay, so your ECG is on the bottom. Okay, so this is your QRS, T wave, P wave, QRS, T wave, P wave, QRS. Okay, this is a systolic frame. Okay, the mitral valve is supposed to be closed, but because the valve is incompetent, you have mitral regurgitation. Again, this is your color flow Doppler. Okay, flow towards the transducer is going to be different shades of red. flow away from the transducer, different shades of blue, or if you have turbulence, you get a mosaic color. Remember, mitral regurgitation, blood is going to flow from the LV cavity across the mitral valve into the left atrium, hence it's different shades of blue. Your transducer is right there. So the blood is flowing this way. It's moving away from the transducer. Hence, it's different shades of blue. If it was flowing in the opposite direction, then you get different shades of red. All right, so just to go over the anatomy, okay, this is a parasternal long axis view. That's your anterior mitral leaflet, okay. We talk about a mitral valve plane. This is what I was talking about for mitral valve prolapse, which it extends from the AV junction up to this point right there. And you know, when the mitral valve close, it's supposed to be within a certain outside a certain distance from that plane. If you look at this, you can see that the anterior leaflet is bowing backwards a little bit. It's bowing backwards. So this will be mild prolapse of the anterior mitral leaflet. Remember what was said, that if you have prolapse of the anterior mitral leaflet, you expect the jet to go posterior. Okay? If it was prolapse of the posterior leaflet, then the jet would go anterior. And for those of you who are doing exams, that they will bring something like that, because if you see that, then you should suspect mitral valve prolapse. All right, this is a case of prolapse of the posterior mitral leaflet, and that's you don't need to measure anything. You can see that so this is the anterior mitral leaflet, and this is the posterior mitral leaflet. You see it bows all the way back into the left atrium, so you expect the mitral regurgitation jet to go anterior, so go up this way. Okay. Prolapse of the posterior mitral leaflet. Now, M-mode echo is important, and those of you who are doing an exam, you're gonna get this. You're gonna get it because it's sort of classic. They love it, so you will get it on your exam. So you have to know what the M-mode feature of mitral valve prolapse looks like. Remember, when you have mitral valve prolapse, the leaflet bows towards the left atrium. So if you look at your M mode, so on top you have your two-dimensional echo, okay? Your cursor crosses these structures. So the first thing the cursor encounters is the chest wall, then the RV wall, RV cavity, the septum, then it crosses the mitral valve, it crosses the left atrium, and then the posterior wall. So those are the same structures you see down here. Okay, the chest wall, the RV wall, the RV cavities right there. This is your septum right there. And then your mitral valve is right inside there. It's your mitral valve. Below that, you have the left atrium. The ECG is there for a reason. Systole is from the beginning of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So this is our mitral valve right inside there. Okay, so again, mitral valve opens in diastole. You can look there. It opens in diastole. Okay, this is your E point, F point, A point, C point, and your D point. Okay, so mitral valve opens in diastole. In systole, you see it bulges towards the left atrium. So this is the mitral valve prolapse of the mitral valve. Okay, because this is in systole, this is diastole when the mitral valve opens. your E point, F, A, C, and your D point. You have to know what these different points stand for. But the mitral valve opens in diastole. It's normal. That's what you're supposed to get. And so you have to know what your normal M mode of the mitral valve looks like. And if you've been looking at these, you know that the leaflet going backwards like this is not a normal thing. So this is mitral valve prolapse, and you're going to get it in the exam. So RV, right ventricle cavity, septum, left atrium, prolapse of the posterior leaflet, and in diastole the mitral valve opens. All right, so we discuss mitral valve, mitral regurgitation. And when we say you have mitral regurgitation, it could be secondary to valvular pathology. The mitral valve itself may have some type of pathology. I went over the different cause. Or it could be due to dilatation of the valvular, the annular ring. The mitral annular plane might be dilated because the whole heart is dilated. So it prevents proper closure of the mitral valve. When you have someone with significant mitral regurgitation, you should move to the next level to find out what's causing this mitral regurgitation. It's important to determine the cause of the mitral regurgitation, because that will decide, that will determine how you're going to fix this patient. Okay? So you have to look at the mitral valve apparatus. And the mitral valve apparatus consists of the leaflet itself, the mitral valve leaflets. Remember, you have an anterior mitral leaflet and a posterior mitral leaflet. So the leaflet itself. The coordinate tendonae, which anchors the leaflet to the papillary muscles. The mitral annulus, which is that, right where the juncture of the left ventricle and the left atrium, where the mitral valve anchors into the heart. That's the annulus. And then the papillary muscles itself, which are located in the left ventricle, and the coordinate tendonae attached to the papillary muscles. So if you cut the heart in two, it will look something like this. So this is papillary muscle right here. Okay, it's another one. So on the left side, you have two papillary muscles. Okay, and the papillary muscle is a part of the heart muscle. It's a muscle, so it's a part of the heart muscle. So when you have someone who have a heart attack or a blockage of the blood vessel around the heart, because it's a part, the papillary muscle is a part of the heart muscle itself, it can become what we call ischemic, subjected to decreased blood flow, or the muscle can die. Okay, if the patient have a heart attack, the muscle can die, and sometimes it ruptures. Okay, so this is a papillary muscle right here. Then these little structures are what we call the coordinate tendonae. Okay, and they anchor the leaflet, the mitral leaflet. So the annular ring would be just, the juncture between the left atrium up here and the left ventricle. Okay, so this is the mitral apparatus. So when we talk about the mitral apparatus, it's not only the mitral leaflet itself, but those four structures, and any one of those structures that have a significant abnormality can give you mitral regurgitation. So when someone presents with mitral regurgitation, you have to determine the cause for the mitral regurgitation. You can't just say mitral regurgitation and that's it. It's important to determine the cause. And patients who present with more than moderate mitral regurgitation, it's recommended that they get, if you don't, if the cause is not readily available, you should do a transesophageal echo to determine the etiology. Okay, mitral valve, the coordinate tendineae, papillary muscles. Okay, so it's important, if you're not sure what's causing the mitral regurgitation, you have to go on to a transesophageal echo to determine the etiology of the regurgitation. All right, so in this case, this patient had prolapse, and you can see the regurgitation. So the prolapse of the A1 segment, the papillary muscles. All right, so you have to determine the mechanism of the mitral regurgitation, because that's going to lend itself to how you fix it, either repair or replacement. Okay, so you can either repair the mitral valve or you can replace it. Remember, repair is always better than replacement. Patients do worse if you have to replace the valve. So you have to determine the mechanism of the mitral regurgitation. You have to also look at the left atrial size, because the more mitral regurgitation you have, the greater the left atrial size. You have mild, moderate, and severe. So patients with severe MR are going to have a larger left atrial size. You have to also determine the left ventricular size. That's going to help you to decide on the severity and timing of surgery. So if you have mitral regurgitation, significant mitral regurgitation, what that means is you have a lot of blood flowing backwards from the left ventricle into the left atrium. So the left atrium is going to receive tremendous amount of blood, because the normal amount of blood that would be in the left atrium plus the blood that you're pushing backwards. So the left atrium is going to be dilated and contains a lot more blood. So in diastole now, when blood is flowing from the left atrium into the left ventricle, it's going to pump more blood into the left ventricle. So the left ventricle eventually is going to get more blood. So that's why the left ventricle dilates over time, and the left atrium also dilates over time. So dilatation of the left atrium and left ventricle is a feature of significant mitral regurgitation. The ejection fraction also helps you to determine the timing of surgery. So if you remember what the definition of ejection fraction is, it is the the end diastolic volume minus the end systolic volume divided by the end diastolic volume. That is what the definition for ejection fraction. So it's the end diastolic volume minus the end systolic volume divided by the end diastolic volume. So let's analyze what's happening. So with mitral regurgitation, the end diastolic volume, because you're pumping a lot more blood into the LV in diastole, that end diastolic volume is going to go up. Your end systolic volume is probably going to be about the same, okay, or less, and your end diastolic volume, So when you have significant, if the heart muscle is competent, if the heart muscle is normal, patients with mitral regurgitation is going to have a supernormal ejection fraction. Okay? Over time, however, the mitral regurgitation can weaken the heart muscle because it's coming under significant stretch. So over time, it can weaken the heart muscle. So if you have a patient with significant mitral regurgitation and the ejection fraction is 50%, that the real ejection fraction is probably 30%. So we use ejection fraction to determine one of the determinants of when to do surgery. So you should do surgery in patient with significant mitral regurgitation if the ejection fraction is 60% or less. If you gonna do surgery with ejection fraction 50%, that's probably too late, because when you repair or replace the valve, you might see that the ejection fraction fall right there on the table to 30%, and the patient develop heart failure. So timing of the valve repair or replacement is crucial in patients with mitral regurgitation. You want to fix the valve before the ejection fraction falls too low. Okay. All right. And that can also be an exam question. So how do we assess the severity of mitral regurgitation? Okay, so if you work in the echo lab, you see a lot of patients coming in with mitral regurgitation. You have to determine, is this mild, moderate, or severe? Or even if you're a practicing physician and patient come to you, you have to determine the severity of the mitral regurgitation, because is the shortness of breath related to the mitral regurgitation, yes or no? So these are the methods that we use to assess the severity of the mitral regurgitation. We use color flow Doppler. Okay, that's one method. We use the color flow Doppler method. You can use continuous wave Doppler. We look at the pulmonary venous flow. We can do what you call regurgitant fraction, regurgitant volume, and then we use the PISA method. Okay, we went over all of this when we did hemodynamics, so this is just a revision for you guys. So when we use a color flow Doppler, we we just look at the regurgitation using the color flow. It is not a very accurate method, but it will give you a determination. You can get a sense of is this mild, moderate, or severe. So you're looking at the area that the regurgitant jet produce, and a small jet implies mild mitral regurgitation. A large jet implies severe mitral regurgitation, but not always. As we say, you have to use other things. You remember we went over vena contracta. When you have mitral regurgitation, blood is flowing from the left ventricle across the mitral valve into the left atrium. Okay, that's regurgitation. So you're going to produce a series of concentric shells in the left ventricle. Okay, so the regurgitation is occurring across the mitral valve into the left atrium, but it's going to set up a series of concentric shell in the left ventricle. The PISA, so-called PISA method, proximal isovelocity surface area. The regurgitation is occurring across a area. The regurgitation is occurring across an area. That area is not a fixed area. That area is a dynamic area, which varies with the severity of the regurgitation. And that is how we come up with the EROA. The EROA is actually the area through which the regurgitation is occurring. EROA, effective regurgitant orifice area. But if you were just to measure the linear, the width of that regurgitant area.
Better.
Okay.
I remember reading just like you.
Yeah, mute your computers, please. Okay, so So if you were to measure the linear width or the width of that regurgitant EROA, effective regurgitant orifice area, you get the vena contracta. That's what we call the vena contracta. Let me see if I can draw it, because you have to understand, because you're going to get this in the exam, all right? There's no two ways about it. You're going to get it in the exam. Let me see if I can draw it. So what I'm saying, if this is the mitral valve right here, okay, and if this is the left, so this is the left ventricle below, and this is the right atrium right there. Okay, and this is the mitral valve.
Left atrium.
Yeah, left atrium.
Oh. Left atrium on top.
Yeah, left atrium on top, right. I see you're paying attention. All right, so this is left atrium on top right there. Okay. And this is your mitral valve. Let's mitral valve right there. Okay. So your left atrium is right up here, LV is right there, mitral valves. So when you have mitral regurgitation, when the LV contracts, it's going to force blood across the mitral valve into the left atrium. So this is the regurgitation. Remember, we say you're going to get a series of concentric shells into the LV. So a series of concentric shells in the LV. And this is how we can calculate what we call the EROA. So if you just concentrate on this little portion right here in the mitral valve, if we were to take that out, what I'm saying to you is that the regurgitation is occurring across a certain area. So the regurgitant jet, the jet that's going backwards into the left atrium, is going to occur across an area, and you can calculate this area right there. Okay, so it's occurring across an area. But if you can also measure the linear dimension, the width of the jet, the width of where the jet is going backwards, and that's what we call the vena contracta. So if you can use your color flow for that. So the width of the neck, or the narrowest portion of the jet, which is called the vena contracta, just measure it. If it's greater than 0.7 centimeters, you have severe mitral regurgitation. If it's less than 0.3 centimeters, then you have mild. And anything that falls in between is moderate. So that is the vena contracta. And we can also assess this EROA, effective regurgitant orifice area, using the conservation of mass principle. Remember what we said? The flow, the regurgitant flow, so that's the flow going backwards from the LV into the left atrium, is equal to the flow at pizza, okay? So flow is equal to area times velocity. Flow is equal to area times velocity. So if you're talking about the regurgitant flow, okay, the regurgitant flow is equal to the area through which the regurgitation is occurring. So that is the E R O A times the velocity. That's a mitral regurgitant velocity. Okay, so that's the regurgitant flow, and that is equal to the flow at pizza. So the flow at pizza, remember what we said, you get a series of concentric shells. Okay, So are hemispheric shells in the LV. So the area, so again, the regurgitant flow is equal to the flow at pizza. The flow at pizza is equal, any flow is equal to the area. So the area of a hemispheric shell is 2 pi r squared. And the velocity that we're talking about is the Adelson velocity. So that is, you adjust your velocity, your color flow velocity. We talk about a baseline shift, and the velocity that gives you that nice hemispheric shell is the Adelson velocity. So, you know, the radius you measure from the baseline to the hemispheric shell. So the diameter, this is the radius because it's a hemispheric, so it's half of the hemisphere. So this is the radius. Okay. So you measure it on your machine, you plug it in the equation, you know what pi is, Adelson velocity you get in the machine, so you can calculate this EROA. All right. Effective regurgitant orifice area. It's the area through which a regurgitation is occurring from the LV into the left atrium. The greater the regurgitation, the greater the area. The smaller the regurgitation, the smaller the area. All right. All right, so let's go back to this. So this is your mitral regurgitation, okay? Left ventricle is on top, left atrium is below. It's the apical four-chamber view. This is a diastolic, sorry, this is a systolic frame. The mitral valve is supposed to be closed, but the valve is incompetent for whatever reason, so you have mitral regurgitation. So this is, if you look at this, the color does not occupy a significant area, and so you could call this mild mitral regurgitation using color flow. The color flow is not very accurate, but it can be used to some extent. So you have to use your color flow along with other features of the mitral regurgitation. So your transducer is there. The blood is flowing from the LV into the left atrium, away from the transducer, and you get varying shades of blue. You actually get a mosaic color, a mixture, because you have turbulence. So with severe mitral regurgitation, the color, the definition, it occupies more than 40% of the left atrial area. Okay, but if you measure the vena contracta, that's the width of the neck through which the regurgitation is occurring, it's usually greater than 0.7 centimeters, and that suggests severe mitral regurgitation. So this is what it looks like. So LV is there, left atrium is there. The color is, so the regurgitation is going from the LV into the left atrium. Tremendous amount of turbulence. You can see the mosaic color. So this narrow little neck right there is your vena contracting. You just measure it. Okay, you do a baseline shift in the in your using the color bar. You do a baseline shift, and then this velocity right here is the Adelson velocity. Okay, so you just plug those in the equation and you get it. If you're gonna, the radius is from right there to right there, so you can measure everything on your color flow. So you're measuring the radius, it is from right there to there. That's the radius. Remember, it's an hemisphere, so it is not diameter. It's just half of a sphere, so it's a radius. Okay, it's not a complete sphere. This is just an hemisphere. Okay. All right, so the regurgitant flow is EROA times the mitral velocity, peak mitral velocity. The flow at pizza is 2 pi r squared times the Adelson velocity. So all right, so that's using color flow. But you can also use continuous wave Doppler to evaluate the severity of mitral regurgitation. With mild mitral regurgitation, the spectral recording has a soft density with a rounded contour. It's not very dense, and you have to use this. It's a very good. It's much more accurate than the color flow to determine severity. So a very soft density, faint contour suggests mild mitral regurgitation. Whereas severe mitral regurgitation, you have a very dense triangular contour. So again, your apical 4-chamber two-dimensional echo is on top. The cursor is across the mitral valve, sample volumes at the tip of the mitral leaflet, and these are your mitral regurgitation envelopes. They're systolic envelopes. Your ECG is on top. Systole is from the beginning of the QRS to the T wave. Okay, so you have these systolic envelopes. They're faint, suggests mild mitral regurgitation, as opposed to these, were very dense. Okay, and the contour is triangular. That make the case even more for severe mitral regurgitation. So dense C-doubler envelope. Okay. Pulmonary vein flow. You cannot talk to me about the severity of mitral regurgitation unless you give me a pulmonary vein flow. You have to do a pulmonary vein flow. So with mild mitral regurgitation, you get a systolic predominance. And with severe mitral regurgitation, you get systolic flow reversal. That's crucial. Okay, so with mild MR, pulmonary vein flow is normal with systolic predominance. And with severe MR, the pulmonary vein flow, you get systolic flow reversal. So apical 4-chamber two-dimensional echo is on top. It's your cursor. Pulmonary veins are way down here. So you have to do the pulmonary vein. Pulmonary vein flow is done using pulse wave Doppler. Okay, and then your ECG is there. Okay, so these envelopes are above the baseline. That's because your transducer is right there. The pulmonary veins are flowing into the left atrium. The flow is towards the transducer, and it's above the baseline. The envelope are above the baseline. You have a systolic component and a diastolic component. You have systolic predominance. You see that the systolic velocity is greater than diastolic velocity. This is what a normal pulmonary vein flow, or if you have mild mitral regurgitation, this is what you're going to get. So you get a systolic, diastolic, and an atrial flow reversal. Remember, when the atrium contracts, it's going to push blood backwards into the pulmonary veins. Okay, and then this is where you have severe mitral regurgitation. See the systolic, so from here to there, systole is actually reversed. You don't see clearly, but systolic flow reversal. This is, the diastolic component, atrial flow reversal. It's right there. All right, so I went over this in explaining the vena contracta. Again, the PISA method of assessing mitral regurgitation. This is what you're going to get. You're going to get a couple questions on this, so you need to know it. So the PISA stands for proximal isovelocity surface area. Okay, you get your 4-chamber view. Again, the regurgitant flow, EROA times the mitral velocity is equal to the flow at pizza. It's the area of an hemisphere is 2 pi r squared times the Adelson velocity. If you rearrange the equation, you get the EROA equal to this. Effective regurgitant orifice area. That's the area through which the regurgitation is occurring. So just think about it. The blood is going from the LV into the left. It has to go, it's not going to occupy the whole of the mitral valve. It's just going to occupy a certain area depending on the severity. And these are hydraulic principle. So they have done numerous studies to show that this is what occurs, and it also occurs in the heart. So we can use the EROA, the area through which the regurgitation is occurring, to determine severity. The larger the area, the more severe the regurgitation. So if you were to draw it, your left ventricle is there, left atrium is right there. This is the regurgitant flow going from the LV back into the left atrium. And in the left ventricle, you get these series of hemispheric shells, concentric shells. Okay, so in real life, so two-dimensional echo. So this is the regurgitation coming from the LV across the mitral valve into the left atrium, and this is the hemispheric shell that we're talking about. Okay, you do what we call a baseline shift on the color flow. This number is your Adelson velocity. This is what you use, but see, it's in centimeters per second. Okay, so you just plug these things in the equation. Very important. If you should, if you're doing echoes, you should if you're doing echoes, you should try and adjust the Adelson velocity to 40 centimeters per second. Okay, should try to do that adjustment, because if you can adjust your Adelson velocity to 40 centimeters per second, and your mitral regurgitation velocity is 5 meters per second, which a lot of mitral regurgitation is about 5 meters per second. So if these numbers are exact, so you adjust the Adelson velocity to 40 centimeters per second, and your mitral regurgitant velocity is 5 meters per second, and let's say you do this adjustment. Well, this adjustment, a lot of your mitral regurgitation is going to be 5 meters per second. But you have to convert this 5 meters per second into centimeters. The units have to match. So you convert this 5 meters per second to centimeters per second. And if you plug it in the equation, you'll get your EROA equal to R squared over 2. So this is a very easy formula to use, because all you have to do is measure R and plug it in the equation, and you'll get the EROA, okay, instead of going through all of this. So if you adjust your Adelson velocity to 40 meters per second, and the mitral regurgitant velocity is 5 meters per second, then the EROA is equal to R squared over 2. Very easy formula to manipulate. All you have to measure is the radius. In the same breath, if your Adelson velocity is 30 centimeters per second and your mitral regurgitant velocity is 5 meters per second, then if R is greater than 1 centimeter, the MR is severe. Because if you plug that, R greater than 1 centimeter in the equation, you're going to see that your EROA is going to come out to be more than 0.4. You will get, if your EROA is greater than 0.4 centimeters squared, then the mitral regurgitation is severe. If the EROA is less than 0.2 centimeters squared, then the mitral regurgitation is mild. Okay, so a larger area suggests more worsening or worse mitral regurgitation. A smaller area suggests less or a small mitral regurgitation. Okay. All right. So it's important to measure the regurgitant volume or regurgitant flow. You can measure regurgitant flow. Remember, we said the regurgitant flow is the EROA, the area through which the regurgitation is occurring, times the TVI. Okay. So what you do first, if you have to calculate the EROA first, and we went through the method of calculating the EROA. You have to calculate that first. And if you calculate the EROA, effective regurgitant orifice area, then you can calculate the regurgitant volume, because the volume, volume similar to flow, but if you're talking about volume, instead of the velocity, you have to use a TVI, time velocity integral, to get the volume. So the volume is the area times the TVI. The area that you have the regurgitation occurring is the EROA, effective regurgitant orifice area. If you multiply that by the TVI, time velocity integral, so you get this is your mitral regurgitation. All you do, planimetry, you're just playing around the mitral envelope, and that will give you the TVI, and that will give you the regurgitant volume. Okay, so you can calculate the regurgitant volume. So that you do planimetry of the envelope. So the regurgitant fraction is just equal to the regurgitant volume divided by the mitral inflow. You can calculate the flow going across the mitral valve. Again, flow is equal to area. Flow is equal to area times velocity, okay, or area times TVI. Okay, so you're talking about the flow across the mitral valve in diastole. So it's very important. So you have to visualize these things. If you're just trying to memorize it, it doesn't work. It does not work. You have to visualize it, understand it. So I showed you how to calculate the regurgitant fraction. Okay? Remember, when you have regurgitation, the more blood going backwards into the left atrium, it's going to be the greater the regurgitant volume, okay, and the greater the regurgitant fraction. It's just, straightforward, common sense approach. The worse the regurgitation, the more volume that's going to go back. And to calculate the volume that's going back into the left atrium, you have to use your flow principles. So the flow or the volume is equal to the area times TVI. So the area that we're talking about is, let me just go back. So the area is the EROA, okay? Okay, that's the area through which the regurgitation is occurring, and then you get the TVI. That's give you the regurgitant volume. The regurgitant fraction is equal to the regurgitant volume divided by the flow across the mitral valve, the forward flow across the mitral valve. The forward flow across the mitral valve, any flow is equal to area times TVI. So the area of the mitral valve now. So the mitral valve, so right at the annulus, that's where you're going to do the area of the mitral valve. So the area right there is, it's a circle, so it's pi r squared. That's the area. So the area right there is pi r squared, okay? And you multiply by the TVI, okay? So it is done. So when you get the mitral, when you in the apical four chamber view, you're gonna measure the annular diameter, the diameter of the mitral annulus. The area is pi r squared. So again, radius is d over 2. Diameter divided by 2 is the radius. So you just plug that in the equation and you get the area. Then the TVI is the mitral inflow envelope. And you just plane the mitral inflow envelope and you get the TVI. You multiply by that and that's give you the, okay? All right, so you're going to need to practice this, okay? Again, this is just going over what I just said. So the TVI of the mitral inflow spectral display and the mitral valve area pi r squared because it's circular. All right, so this is a table that you need to know. This is the table. This is where you're going to get tested on. Okay, so you have to know what's in this table. Okay, this is what you're going to get tested on. So they want you to know, you know, they're going to give you a bunch of stuff and you have to determine whether this mitral regurgitation is mild, moderate, or severe. So let's go over the table. All right, so for severe mitral regurgitation, the left atrial size is going to be dilated. I went over that. I explained why the left atrium is going to be dilated. So for severe mitral regurgitation, left atrial size is going to be huge. For mild, it's going to be normal. It shouldn't be enlarged. The LV size, huge. And I explained that in going over the mitral regurgitation. So large left atrial size, large LV size, suggests severe, okay? In mild, it's going to be normal. The mitral leaflet and supporting apparatus, usually normal for mild. Okay, you can have flail leaflet, you can have rupture papillary muscles. It's usually abnormal for severe. So if you're talking about severe MR, these structures are usually abnormal. When you talk about the Doppler now, the color flow jet, if the color flow jet occupies more than 40% of the left atrium, it suggests severe. If it's less than 20% of the left atrial area, it suggests mild. Anything in between those are moderate. The mitral inflow, and this is important, mitral inflow. So I've seen technicians give me paper and then, you know, severe MR, and then the mitral E velocity is less than 1.2 meters per second. It doesn't work. If you understand what severe mitral regurgitation is, you can't have a severe regurgitation in the mitral E velocity less than 1.2 meters per second. So let's just look at this a little bit. So when you have severe mitral regurgitation, what you're saying is that you have a lot of blood flowing from the LV into the left atrium. So a lot of blood is going into the left atrium. In diastole, when the mitral valve opens, then there's a lot of blood flowing from the left atrium back into the LV. So the E velocity, which is a measure of the left atrial volume, is going to be tremendous. So the E velocity usually is greater than 1.2 because there's a lot of blood in the left atrium. So this is a quick tip off. If the E velocity is less than 1.2 meters per second, you don't have severe mitral regurgitation. Okay. So for mild, you have A wave dominance. This is the mitral inflow. Again, C doublet, jet density, very dense, triangular contour of the mitral envelope. So very dense triangular contour. You know, for mild mitral regurgitation, it's very faint and it's rounded, parabolic. Pulmonary vein flow, okay, you get systolic flow reversal, okay, systolic flow reversal, important. For mild, you get systolic dominance, okay. For moderate, anything that falls in between is moderate. Vena contractor, we went over how to measure the vena contractor. If it's greater than 0.7 centimeters, it's a linear measurement, so it's not an area. So if it's greater than 0.7 centimeters, suggests severe mitral regurgitation. If it's less than 0.3, suggests mild. Regurgitant volume, greater than 60 mLs. Okay, so severe suggests there's a lot of blood going back to the left atrium. So the regurgitant volume, and we went over how to measure regurgitant volume. If it's more than 60 mLs, severe, less than 30 mLs, mild. Regurgitant fraction, greater than 50%. So if you have more than 50% of the blood going backwards, I mean, that sounds severe to me. And less than 30% is mild. The EROA, effective regurgitant orifice area, greater than 0.4 centimeters square suggests severe MR. Less than 0.2 centimeters square suggests mild. You have to know those people well. If you're a practicing echocardiographer, you have to know the table, because you have to know what's mild, moderate, and severe. So you have to know the table, okay? And then people who are doing the exam, they're going to test you on this. Okay, so we're going to stop here.